So now it is a time for debate, and debate is very interesting. PTBD versus ERCP, and we have got eminent speaker Dr. Vinay Dhir with us. So, sir will start the talk now.
Thank you very much. At the outset, I would like to thank Dr. Sanjay Kumar for having me here. I would also like to say that debate, there is actually very little debate. Both the techniques are excellent, both the techniques are needed. It's only the decision as to when to use ERCP and when to do PTBD is the question. So in expert hands, both techniques are very, very good. So little in brief about biliary stenting. So you use it in a pre-operative setting. Patients who are going for neoadjuvant chemotherapy or palliative chemotherapy, and rarely patients who are symptom control or in cholangitis. The main indication is the second one, where patients are waiting for neoadjuvant chemotherapy or palliative chemotherapy. Two major types of stents, you must have seen both of them today. The plastic stents were introduced almost 45 years ago by Virendra, and metal stents were introduced later in the 1986. These two stents are still available with us. The difference between two is plastic stents have a smaller diameter, so they block early, 30 to 50% dysfunction in 3 months. Self-expanding stents are larger diameter, so stent dysfunction is lower. So when do you do what? Plastic stents are usually used for patients who have survival rates of less than 3 or 4 months, larger tumors, liver metastasis, while metal stents we use for smaller tumors where you expect the patient to live longer. What about cost efficiency? Now this study was for distal obstruction, but I guess it applies for both ends, where it says that the stent exchanges with plastic stents are more frequent. So in the end, if you look at the costs, there is no significant difference between plastic stents and metal stents. So after this, people started recommending that you should use metal stent as a preference. However, there are still differences of opinion about that. In Clarkson tumor, the first thing is plastic stent or metal stent, how many bile ducts to drain, how much parenchyma to drain, and what technique. So MRCP is a must. Please do not do a hilar tumor without an MRCP. You will end up in problems in cholangitis. So a good MRCP, which gives you a roadmap, gives you an idea whether you need 1 stent, 2 stent, or 3 stents. So MRCP gives you basically left lobe you have segment 2 and 3 drainage, and right lobe you will have segment 5 which goes up and segment 7 which goes down. So 3 stents may be needed for 7, 5 and 2 and 3, but 1 or 2 also are okay. So this was a study few years back about SEMS versus plastic stents, and the conclusion was that SEMS have longer patency compared with plastic stents. Uncovered stent should be used. You know the reason why, because the cover will block the side branches. But if you have a patient with hilar block in whom you have no diagnosis, and this is a very important point, if you do not have a tissue diagnosis, please do not put an uncovered SEMS, because getting a tissue diagnosis after placing uncovered SEMS becomes very, very, very difficult. I keep getting patients like this, where stents have been placed and they refer to me for EUS diagnosis. You don't see anything, especially in cholangiocarcinomas. So if an undiagnosed patient with hilar block comes to you, first place a plastic stent and confirm the tissue diagnosis, and later on, if need, place a metal stent. If you have a confirmed diagnosis, plastic or metal, still the jury is out. There is a recent paper 2 months back which says that bilateral plastic stents are as good as metal stents. So this question has not been answered. The era of one stent versus two stent has given way to how much of the liver are you draining, and this is based on the studies. If you drain both lobes or one lobe, and then how much have you opacified. So if you opacify both sides and drain only one, then the patient will not live long because there will be cholangitis. So you put as many stents wherever you have injected. So we have replaced injection with air cholangiogram. We don't inject contrast now. So these are the examples. One lobe opacified and same lobe drained, it's okay, not bad. But if you opacify both lobes and then place a single stent in one lobe, that is a death warrant for the patient. Don't do that, or you will need a PTBD later. So this concept of draining 50% of the liver has come almost a decade ago and has become a standard now. So it's not the right lobe or left lobe or one stent or two stent. You look at the volume of the liver. Your stent should be draining 50% of the liver volume. If you don't do that, again cholangitis is likely to happen. And there are two techniques side by side which was shown today very nicely, and this is a video, I'll miss it. This is simple, nothing major about it. And then you have stent in stent where you place one stent and through that you place another stent. More difficult, more clumsy, but loved by people in Korea. They keep publishing this and they keep showing that stent in stent is better. However, it is not reproduced by other people where they say side by side stent is better. Now comes the issue of EUS versus PTBD. So type 1 and type 2 we would go for ERCP. Why? Because it's simple, straightforward, multiple sessions are not required and you can get the same result with lesser complication rate. The issue changes with type 3 and type 4 blocks, where it has been shown that the successful palliation of cholestasis is done better by interventional radiology. So complex blocks, the role of interventional radiology is much greater. Type 3 and type 4 blocks, be careful because we don't want undrained segments to be left behind. Recently, over the past few years, I hope this plays, the role of EUS in type 3 strictures is coming up. So what you see here is a patient in whom we have, can I fast forward it so that we can do it fast? So you see there are already two metal stents, ERCP, two metal stent, patient is still in cholangitis. So what you do is you use EUS to drain the left segment. So you've seen the hepaticogastrostomy today. We can't fast forward it. Anyway, so guide wire, cystotome, what I showed you today, and then a stent straight away, and the patient was relieved of cholangitis. So draining both left and right side of the biliary system is possible with EUS. So you can do a hepaticogastrostomy or you can do a hepaticoduodenostomy from the duodenum and drain the right and left segments. So this is an evolving concept. We do not have definite data, but this is very exciting for us endoscopists to drain these segments by EUS if ERCP is not working. I think we have seen this case before, so let's forget it. And post-operative biliary, I'm not able to fast forward, so anyway. So this is post-operative setting, anastomotic stenosis. करो यार थोड़ा fast forward नहीं कर सकते क्या उधर से? Okay, anyway, so this is what I was going to show. ERCP in this setting, post-operative stenosis, you can use an enteroscope or you can use a colonoscope, go to the anastomosis, and there is a very high success rate of this procedure. in expert hands, almost you will reach the anastomosis in close to 75% of patients with persistence, and you can find out the anastomosis. And so there is no need of doing a, see there is a stenosis there, you can dilate it with a balloon and clean whatever is there inside. So that is another option in a post-operative setting. I think I should forward this also. And then what is the last one? Let's leave this. I'll leave this. So my conclusions are, please understand the anatomy. Single most important lesson you want to draw from here, understand the anatomy if you are dealing with a hilar stricture. Don't just place one stent and come out. Drain more than 50% of liver parenchyma. Very, very, very important. ERCP is good, very, very good for type 1 and 2. Interventional radiologists to be involved in type 3 and type 4 obstruction, but there is an emerging role of USBD in type 3 obstruction. Thank you.
Thank you so much, sir, for such a wonderful lecture. Now we will proceed with percutaneous transhepatic biliary drainage, and the speaker is Dr. Amar Mukund, Professor ILBS Interventional Radiology, and then we can have discussion.
It seems they are very friendly with each other. There was no debate the way sir spoke. Dr. Dhir has not taken it as a debate. He doesn't want to hurt the interventional radiologist. I don't like debates. Actually, there is no debate in this topic. That's what you said, because things are quite clear by now. But let's see what he says.
So, good evening all. At the outset, I would like to thank Sanjay sir for having me here. And I would also like to thank Vinay sir for actually telling us interventional radiologist has a definite role in type 3 and B, and EUS is an emerging modality. And I'll take it further, like how we compare even with EUS, even if in type 3 and type 4. So first of all, we should know about PTBD. What exactly is PTBD? I know all will say, yes, we know what PTBD is, but yes, still I would like to say what PTBD. PTBD is a broad term, which is often loosely used for different biliary drainage procedures, and it includes percutaneous external biliary drainage. You just drain externally, you call it PTBD. Then internal external drainage, you cross the stricture, you connect a bag, it becomes internal external drainage. Then you clamp the bag, it becomes internal drainage. And then you put a biliary metallic stent, again it is a PTBD. So everything is PTBD, 4 things are PTBD. No, it cannot be like that. So let us come one by one how we call. So different clinical scenarios, we have actually seen palliative, preoperative cholangitis. Coming to palliative care, yes, type 1 block, there is no debate. Till the time there is no cholangitis, no debate. Yes, ERCP should be the first. I echo the sentiments of Vinay sir and everybody sitting here. Everybody would like to do in type 1 blocks. Yes, till the time you are able to do, please do it. Type 2, again, we don't know which side the wire will go, left, right. We are always in dilemma. Then we come to, okay, we are draining 50%. Again, okay, agreed. But depending on the pathology, we need to know which is better. CA gallbladder, it is better to drain on the left side because the chances of secondary involvement would be more on the right side. So it's better you know what side you are draining, and that's how you can do with PTBD. You choose the duct which you want to drain. Then preoperative, again you have to be very careful. So it depends on the surgeon what he wants you to drain. If it is a right extended hepatectomy, he would like you to drain the left. So if you go into the left, very good. But if you go into the right, probably the right volume will increase, the left will go down. You don't want that. So again, it's better. Malignant obstruction, patient in cholangitis, cholangitis abscess. Absolutely PTBD and nothing else. Why? Because right posterior ductal drainage is needed, and that's mandatory. There is no question not draining it. You drain other, very good, but you have to drain posterior. So PTBD has additional advantage of easy catheter exchange, upsizing and quick and easy re-interventions. Why I am using this catheter exchange, upsizing, quick and easy re-intervention? Because wherever there is a data comparing ERCP and PTBDs, it is re-intervention which is coming time and again when I went through the literature. But cholangitis is an area where we need re-intervention. So PTBD is the choice. Now, again, as shown, this is a different kind of stents can nicely be placed by PTBD. Again, coming to some of the data, comparing PTBD with ERCP, this is for hilar cholangiocarcinoma from surgery. They say that PTBD has a low rate of cholangitis, pancreatitis, and salvage biliary drainage and decreased hospitalization cost. So, okay, this is one of the paper, not going. Another meta-analysis and systematic review, 2016, Canadian Journal of Gastro and Hepatology. In patients with advanced unresectable hepatic hilar malignancy, palliation with PTBD seems to be superior. So this is 2016. Coming to the recent meta-analysis, 2023, Clinics, Brazil. What they say? This is one of a very good paper, this which I found where the authors have looked into specifics of drainage in either group, like plastic stents, SEMS, and type of hilar block. They have tried to compare each and every group based on these criteria. And what they found, that PTBD is superior to endoscopic biliary drainage regarding crossover rate, overall post-drainage complication, and post-drainage pancreatitis. Endoscopic is superior to PTBD when it comes to hospital stay, and for palliation, again PTBD is superior. So definitely PTBD has certain advantage. Now coming to some of the data regarding endoscopic biliary drainage. Here, this is a paper which came in 2022, World Journal of Gastroenterology. They say that endoscopic ultrasound has higher rate of effective biliary drainage. Now let us see what they have actually done a review on. So they have taken almost 5 papers. First paper, again, this is surgery comparing to endoscopy. Second paper, it is endoscopy ultrasound with PTBD with ERCP, but here the PTBD group is a historical control done in 2005 to 2008, where EUS was done from 11 to 13. So you go back 15 years back and then you say, okay, that was bad. Yes, that may be bad, but to compare it today to today. Then this is another paper. Here they have used only one plastic stent comparing with metallic stent. So it's not apple to apple. Then comes to Giovannini et al. Giovannini is a very big person. Everybody who does EUS would be knowing him. But the paper which has been quoted over here, it is a multi-center trial, but this mentions about learning in therapeutics. This is the editorial. This is a paper which was presented in 2015 in one of the conferences, but never published. Now, coming to another, it is again a misquoted paper, and finally, the last paper which has been discussed over here, there is no description of PTBD procedure, like how it was done, whether it was external, internal, metallic, non-metallic. Now again, there is a paper which says that EUS guided procedure has a significant advantage and blockage rate and re-intervention rate. But when we compare what we see, that for PTBD group, what they have mentioned, for the purpose of the current study, PTBD referred only to external drainage catheter. So now you are comparing external drainage with endoscopic with metal stent. So this cannot be a comparison. Now, if actually when you do a metallic stenting in both the groups, what do you find? So this is another paper came out in 2020. They said that similar to PTBD, EUS can be effectively. So yes, it can be matched provided you do it accordingly. This is again right side drainage. This is a new technique where left is drained and even right is being drained, and it needs a complex procedures where you place multiple covered stents. But again, this paper also has a problem. All patients in the PTBD group did not undergo internalization of the tube during the follow-up period. So this is what it says. So wherever PTBD is compared and it is said that EUS is comparable or better, there we find that there is a step motherly treatment to PTBD where PTBD is not actually done the way it should be. So the issues with current literature is most available literature compares with ERCP, EUS biliary drainage with PTBD, where patients with PTBD have received just an external drain. Some studies have included internal external drainage catheter with no uniform follow-up for catheter exchange. Some have received plastic stents. Rarely patients have received SEMS via PTBD, and some have historical controls. While most patients with EUS biliary drainage have received metallic stents. So level playing field is needed before we compare two therapies. and making comparable groups. So how can it be comparable? So external PTBD may be comparable to ENBD, like in previous talk we were talking that ENBD is good way of draining in pre-surgical cases. Yes, similarly PTBD can be done, external drainage. Then internal drainage is equivalent to plastic stent. You put plastic stent and you clamp from PTBD, that's again another way. And PTBD SEMS is ERCP SEMS. This was an original article, only RCT comparing US and PTBD. They found no difference with comparable results. So again, both that appear normal. This is again few data which favors PTBD, not going into detail. So what we know by now, bismuth type 2, 3, 4 obstruction need drainage of few or all lobe segments based on clinical need. And as per evidence, PTBD and ultrasound guided, EUS guided biliary drainage scores over ERCP, so there is no doubt about it. Whether there is expertise, no expertise, that's another thing, but these are better technique. PTBD and USBD appear competing modality. This is what literature says. Though fewer studies favor EUS biliary drainage for malignant hilar obstruction, but a non-biased comparison and deep analysis reveals that PTBD not being performed and analyzed with the ideal endpoint in most of the studies, though thus those studies quoting superiority is questionable. So what we conclude, PTBD is a preferred modality in malignant hilar disconnection and severe cholangitis and in pre-op biliary drainage. PTBD stands as a robust therapy for malignant hilar obstruction even in palliative setting if PTBD is internalized and SEMS is placed. EUS biliary drainage needs a higher level of expertise for performing these complex drainages. And definitely I must acknowledge that IRs are far behind in collating and publishing the data. We don't have much data, but whatever data is still, it's favoring us as of now. Thank you so much.
Thank you for a wonderful, not debate, in fact it was, things are very clear. I just have one comment from Dr. Vinay Dhir I want to have, that how is the spyglass cholangioscopy, has it increased the rate of, like we can use in type 3 bismuth, and we are more able to manipulate the wires very effectively?
Yeah, so the bottom line for hilar malignancies, both for them and for us, is expertise. And unlike distal CBD obstruction, where it's okay, hilar block management requires expertise in wire manipulation. You have to understand what you are draining, which segment you are draining, where you want your wire to go, and you should have the expertise to place the wire. He brought it out very well. Unfortunately, he believes that only radiologists can place the wires correctly. That is not right. We can place the wire wherever we want. Right, left, segment 5, segment 8. So, as I said, if you are doing a good MRCP and you are doing an ERCP after that, cholangioscopy becomes really irrelevant. You have to have either yourself or an assistant who negotiates the wire. You tell him, I want it in segment 3, and you should be able to do it. That requires learning, but it comes. There are many people who are doing it. You can place multiple steps and ERCP also. And the problem with cholangio, coming back to your question, is you inject things. You have to constantly flush it with saline. And if it is a complex block and you are not able to do it, you will contact the patient. Because if you are not injecting saline, you won't see anything much. So I am not a big advocate of using cholangioscopy for hilar blocks trying to pass the wire. Better way is use wires which, telephone or something, go into the system that you want, and then change it to a steel wire and go into the
My only point was, once we are near the common hepatic, then it becomes bit easier to put the wire in the appropriate duct rather than when we are just maneuvering it from the...
associated risk of cholangitis because you are injecting things. See, in our practice, we are totally basing our knowledge of anatomy and anatomy. We are not injecting contrast. We only do air pressure because it is known that it will inject. And if you are not able to drain it, this is a short, near mortality unless you got the body is a better drain. So don't inject even say, why do you have to inject that?
Sir, one more question. How do you choose endoscopic ultrasound where it biliary drainage over percutaneous drainage? And any specific reason to do so?
No, it's a very good question. So, the procedure is evolving. The literature is not good, as was mentioned. Both for PTBD and ERCP, the literature is not good. Nobody has honestly tried to find the answer to whether this is superior or that is superior. We have got very good results with regards to radiology, complex loss. So this is a given, right? But the expertise, I think yes, I have expertise. How many interventional radiology experts do you find in the city who can do 3 steps? USP is similar. You have evolving expertise. And you have probably in the city 1 or 2 centers or 3 centers who are experts. But those who have done lots of cases, be confident that they can train the system or that system. And they are doing it. So the bottom line is, I am very confident that I will do this. I will do it and I will not call my IR colleague. If I am not confident, I don't want to risk my patient. I will call my IR colleague. Please do it. So it's a evolving. You first do a pseudo techniques, then you do a corridor, and finally you go to pedicle gastrostomy and anterior drain. So you have to do 150 procedures before you say, okay, now I don't need that. But before that, we need that bill or some fantastic randomized study that says that yours will be better. No, there is no study right now. It's an individual center expertise. Likewise, if for example I am lucky and blessed with not one but 3 great interventional radiologists, very good there. The last week they had a patient, I think, not the best to there was a huge collection just below the liver. Patient was in the ICU. These complications happen in the best of the hands. I am not saying that something bad was done. They are the best. In my hands also, USBD can cause complications. So these things happen, but development of expertise is something. I am an endoscopist. I love doing USBD rather than referring.
So we are running short of time.
Sure.
And thank you so much for such a detailed answer. We had a nice session on ERCP and PTBD. I request all the chairperson and speakers to assemble for a group photograph.